suicide relates to psychiatric mental health nursing and just the psychiatric population in general. What are some characteristics that relate to it, or?
They might be at higher risk for it.
Yeah, they are at higher risk. We'll talk about it a little bit later, but something that you want to take note of is about 90% of individuals that carry out the act of suicide have had a previous diagnosis of a mental health disorder. So something that people commonly get confused is they think that suicide is like a diagnosis or a disorder that actually, you have suicide, or, but it's actually a behavior. So it's carrying out an act. It's defined as behavior. So we know that suicide is taking one's own life. There are some religious undertones that come into play because, of course, suicide is viewed as a sin in some within some religious communities. So there are religious undertones that come into play. The afternoon, so I want to make sure I don't skip anything with you guys. So suicidal ideation and suicide, the act of suicide is gaining more and more attention now. And why do you guys think that is? It used to be confined a lot to the psychiatric mental health realm, and people thought it only happened with crazy people. But why is it gaining more attention, and why is it becoming a more well-funded movement, and those types of things?
Are we getting more increased awareness of mental health issues, or are people getting, like more diagnoses of mental health issues?
Yeah,
I guess
more diagnoses of mental health, and also it's spilling out into regular society. We're seeing younger children and adolescents committing suicide. It's especially more prevalent in the educational system. And so now it's just becoming more aware. Yeah.
I was gonna say, do you think like social media plays a part in that?
Definitely, most definitely, especially the cyberbullying aspect, for having more kids that are committing suicide, adolescents. We had, for a while, we had that string of college kids that was committing suicide, especially that was in relation to sexuality and homosexuality, where like people were hooking up in their dorms and other people were videotaping it, and then kids were going and like killing themselves immediately because they were ashamed and stuff. Just hot messes of things were happening. So yeah, it's precipitating the suicide, like cycles of suicide, and then it's just making people more aware. So it is gaining funding and more exposure. Unfortunately, that means more people are doing it, but at least it is bringing more awareness to it. Like I said, we have 90% of people who attempt or die by suicide, they have a diagnosed mental disorder. The most common one is associated with it is depression, but we also have to remember our psychoses, so our psychotic disorders as well. Chronic illness and pain is one of the, we'll go into the characteristics and risk factors for suicide, and pain and chronic illness, or like terminal illness is a risk factor. And that plays a role when you start looking at physician-assisted suicide, and I think we're in the high single digits or low double digits, like the teens, of states that have adopted physician-assisted suicide, legalized it. They have that final transition plan that they, that individuals will plan and adopt for themselves. This is just some historical perspectives. I left it in there simply because you might be interested in it, but you're actually passed over it, obviously. I.e., suicide's been around for a long time. So, these ages are interesting facts for you and statistics. I'm not going to expect you to memorize these for the exam, for exam 2. It is the 10th leading cause of death overall in the United States. Now, what do you guys think? And some classes have been aware of it. But who commits suicide more? Who carries out the act of suicide more? Men. Who attempt suicide more? Women. So what's the correlation there? Why do men actually carry out the act more? Yeah, they tend to use more violent means. Women tend to overdose more. A statistic that was in here, and I actually did research on it, there are several meta-analyses and active studies is adolescents use the means of suffocation more, so they actually are hanging themselves, which I found that interesting. I thought overdose would be consistent across the board, but it's actually suffocation. So women attempt suicide by overdose more, so they often think that taking a bottle of Tylenol or ibuprofen or something like that's gonna do it. But you can take a lot of substances. It's kind of odd. You think that overdose would be easy, but it's a lot harder than you think. I mean, because you realize, just think how many people are doing heroin on a constant basis, and they live all the time. Like, they pass out, but they come back. Like, you think that you just don't kick it, but a lot of people do OD from it, but I mean, it's harder than it sounds. And still, I wouldn't roll the dice with it. Like, don't go out and be like, you said it'd be okay. No, I wouldn't do it, but if you take Tylenol or ibuprofen, you're just gonna fry your liver. Now that might end up killing you down the road, but. So which is a common misconception about suicide? 8 out of 10 individuals who commit suicide get warnings about their intentions. Most suicidal individuals are ambivalent about their feelings regarding suicide. Most individuals commit suicide by taking an overdose of drugs. Initial mood improvement can precipitate suicide. So read the question very closely. So what do you think? C. And so most individuals actually commit suicide by taking an overdose. And so we know that most individuals actually commit suicide by what? Guns. Yeah, so that's why it's a misconception. So we know that they actually commit suicide by guns, more lethal means. So when you look at suicide rates, now there's a lot of statistics and characteristics throughout this lecture, and it's a long lecture. However, if you take a step back and you're reading your questions, and a lot of these questions on the exam are going to be obviously scenario-based because they're going to kind of tell a story because you've got to get assessment data all thrown in there. But then you take a step back and you look at them and you're like, okay, well this is kind of common sense. Because what are you looking for when it relates to suicide? You're looking for a precipitating what factor? Something that contains what type of event? A stressful event. You know, people that are happy and leading nice, good lives and are content and stuff, they don't just go out and commit suicide. So you've got to have some type of stress factor related to it. So, for single, never married individuals, they're at twice risk of suicide than married individuals. Divorce risk increases, particularly among men, who are 3 times more likely to take their own lives than divorced women. You women just bounce on back. You take the divorce like a duck to water. Us men are just fragile. We're emotionally sensitive creatures. Women do all this. Evidence supports that divorced men are twice as likely to die by suicide than married men. We just can't be alone. Widows and widowers also have been identified to be at higher risk. You notice there's nothing up there about gay men because we jack these statistics all up. Because we can't be alone, we're codependent. They'd be like, oh, Jesus, we can't even do a successful study because we'd be all over the place up here. So there have been longitudinal studies found that can kind of skew these statistics a little bit. Some studies have found that widowed individuals have no effect on suicide rates. Why do you think that might be? That certain studies have shown that widowed individuals have no effect. Can I buy a vowel?
Maybe like different populations being studied, like different sample groups?
Yeah, it depends on the sample because some of these individuals, you might be looking at somebody who led a nice, long, healthy life and died by natural causes. And so the person felt that it was time for the individual to go and they felt that they had a meaningful life. So you never know what kind of group was being looked at. Depending on the sample group and the control group, you can really control outcomes of studies a lot. And then look at this again. Among women, the study showed no significant difference in risk of suicide by marital categories. Y'all just don't care, like I said.
We just get over it.
I know, emotionally void. So women attempt suicide more often, but men succeed more often. Women tend to overdose. Men use more lethal means such as firearms. So that's something to, I mean, you guys have already stated it, but this is definitely something to star, highlight, red pen. So risk of suicide increases with age. This definitely is more common among men. I'm not going to ask you to specify the specific ages. Just know that it increases with age in the male category, male gender. Again, we know that it's males with firearms. With adolescent females, it's suffocation. But in general, with females, it's overdose. So just be able to differentiate those categories. And then how does religion play a role? Well, we know that religion frowns upon it because of religious connotations and undertones, because of suicide being a sin. But how can suicide affect and prevent somebody from committing suicide, committing the act of suicide? They're afraid they could go to hell, of course.
I don't know, I mean, I've heard that.
Yeah, no, that's definitely true. But also being tied with a religious affiliation, we'll learn this a little bit later in the lecture, but closeness with a group or an organization or closeness with family, that actually is going to decrease your chance, because significant relationships, that's something that's going to decrease your chance of suicide. Detachment from community, detachment from family, detachment from affiliation with any meaningful group that, you know, has meaningful relationships associated with it, increases your chance and your risk of suicidal ideation. So if you have a constructive religious, organization that you're affiliated with, that actually helps you cope with struggles that you're going through in your life. This I kind of found interesting. One of the common misconceptions is that lower socioeconomic class individuals are the only people that experience hardship in the world. But a good example to help you remember this is, who's seen the movie Titanic? Okay. Now, why did the ladies, betrothed individual, who's, her fiance, how did he die? And why did he do it? Does anyone remember? Yeah.
Didn't he lose like huge amounts of money and then he put a gun in his mouth or something
Yeah,
like that?
he died because of the Australian in the class. She has to be going to hell. Nobody else in here jumped right in. She talked to us about healthcare right from here. She told us about a movie that was made, our history. Oh, it's pointing, you're saying that example. Yes, the stock market crashed in 1929, and he lost his fortune, and so he killed himself because of it. I mean, it's just money. Who cares? You're going to be poor now, but no, finance is going to have a huge stress on individuals. Another example of this is like the Enron executive. He was like the president of Enron, one of them. I mean, there were several, like the chairman of the board and the CEO, but he was one of the presidents. Whenever it was about to collapse, he lost a huge portion of his wealth when the stocks were degraded, and then also it was going to come out about what the company was doing, and so he drove like a Honda in his Mercedes E-Class or whatever, and put a gun in his mouth and killed himself. He left a note saying how sorry he was that he'd done all the things he did to the people in the company. And then also lower socioeconomic classes. A lot of this is because of their exposure to violence, like we said and talked about in our aggression and anger lecture. And then also unemployment has a huge part and increases stress. What do we know about finances and relationships? What kind of impact does that have on relationships? It increases stress, and it's one of the number one factors for what? Divorce. And we know that divorce really increases your chance for suicide, as we just talked about. And so again, when we talk about lower socioeconomic classes, a common misconception is that the lower socioeconomic classes are really concentrated in higher density urban areas that are predominantly African American. However, we have African Americans coming in as the lowest percentage group of individuals that commit suicide. Your Caucasians are your highest risk for committing suicide. So It doesn't say that it doesn't happen, not to say that it doesn't happen, but the statistics show it inversely related. Now, I was at work last night, and I was comparing the lecture to the book and, looking stuff up, making sure everything was still current. A coworker of mine at Central State, who used to work with me at Our Lady of Peace, he was like, "What are you doing?" I was like, "Oh, I'm preparing for lecture tomorrow." He was like, "Oh, suicide." He was like, "You know how many people have committed suicide that worked at Our Lady of Peace? We should be lucky we got out of there." And I was like, "No, I've never really thought about it. 7 people in the last 8 years have killed themselves that worked at Our Lady of Peace. Isn't that crazy? We really thought about it, and did it in weird ways. We've had some really weird ways. The most recent individual who he didn't know about, so we said it was 6 last night, but then it jumped up to 7 today whenever I was thinking. The most recent guy, he was such a nice guy. We were like good friends at work, colleagues at work, but no one knows the reason. He had a 1-year-old son, newly married, a 10-year-old stepson. He was always real quiet and reserved, but he worked at Our Lady of Peace in the Brook. He worked at the Brook area, and he went to work at the Brook, threw his cell phone away after his shift so no one could call him. He drove from the Brook to a Kroger, and he slit his own throat. You gotta be really sad to do that. If I cut myself shaving, I'm like beside myself. Like, this is ridiculous. I'm like, I'm gonna get, like, I look a mess, my clothes are gonna get messed up, hurts, gonna be messed up for a few days. He slit his own throat. We've had 2 individuals that have shot themselves like in the chest, which is a very odd place to shoot yourself. We've had one person shoot themselves, like put a gun in their mouth. We've had one person who, he was homosexual, and his family was very conservative. His mom knew, his dad didn't know, and then he got an HIV diagnosis and didn't want to tell his family, so instead of having to tell anybody, he shot himself in the face, like didn't put a gun in his mouth or up against his head, he just shot himself in the face, which shows a lot about personality, because he didn't, he had to have a closed casket. I mean, he literally blew his face off. So there's a lot of shame and guilt and regret and remorse there on his part. He just wanted to wipe himself out. And one person that drove in the opposite way into oncoming traffic missed up everybody else, but tried to run head on into people and hit a tree and kill himself. But it was on purpose, it was reported, like he was trying to get several people, and he left a note as well. So lots of people have killed themselves in Our Lady of Peace. So, who's at the highest risk for committing suicide as far as occupational suicides? Which groups are at the highest risk?
I'm not sure back here, but back home it's anesthetist, because they can, no, maybe that's more completion of suicide.
It's individuals in healthcare, so nurses, doctors, dentists, law enforcement officials, people in the Army, and then like bankers, mortgage brokers, like high-powered, not like I'm Jake from State Farm, but like high-powered bankers. And so we're in the high-risk group because of stress and exposure to what we see, because what we see really puts us in the category of trauma, because we see things that are so heinous and gruesome, people dying and people that have been maimed, and hearing the stories that we hear about people being raped and child abuse. It's hard to process that sometimes. So, individuals hospitalized for psychiatric illness, this is something to remember and take a mental note of, is it's 5 to 10 times greater risk of suicide than those in the general population. So again, that correlates with that 90% increased risk. And then what do we know about our SSRIs, atypical antidepressants, and our SNRIs? Is that it increases risk early in treatment. Why? Because they start to feel better. And so all of our disorders, schizophrenia, bipolar, personality disorders, eating disorders, all of them increase risk. And what about insomnia? Why do you guys think insomnia plays a role in suicide?
It causes stress too, sorry.
Yeah, it stresses the body out, but if you've been up for several days, we're talking days on end, like pulling an all-nighter is one thing. But you can actually go into, and especially if you're taking stimulants on top of it, you can go into acute psychosis because of insomnia. And stimulant-induced psychosis is common when people have been abusing methamphetamines or over-the-counter amphetamines like Adderall, prescribed amphetamines, I mean. So stimulant-induced psychosis or psychosis from insomnia, if someone's been having a manic state and have been up for days, they can become very psychotic. So this is common sense stuff. Obviously substances increase risk. Psychosis with command hallucinations, like it's reported the individual that killed the two people at Walmart, Kroger, was having command hallucinations to do so. So your schizophrenic patients, obviously there's a much higher risk for suicidal ideation. Like I said, affliction with chronic pain and disabling illnesses. So this with our studies, with our LGBTQ, I'm wondering how many more letters we can put on that eventually. It's going to be just a sentence. They're at higher risk. It's not necessarily because of lack of acceptance and reconciliation with what they're going through, but why are they at higher risk for committing suicide? Not normally because they can't accept what's going on with themselves, but why? Others can't accept them. A lot of bullying, a lot of, I mean, the transition is very difficult a lot of times when they're going through their process. And you'll take care, especially if you go into psych, or I'm sure if you're in the ER, I mean, because some of these individuals prostitute themselves and get beat up and stuff. I mean, you'll see some of them, but I've taken care of several patients that are going through the process to either transition fully or that are transgender individuals. And when they're going through the transition to try and transition to like fully to another sex, like in that in-between period, the various stages, it's very difficult for them. Like, because you got to put them in separate rooms, and then they don't necessarily look one way or another. They're kind of in an androgynous stage. And psychotic people, especially some of the males that have abuse histories, like perpetrating on, some of them like that, some of them don't and are really mean to, I mean, it's a hot mess. They have it so bad in the hospital, and you're trying to keep them from getting beat up. And I remember telling the class one time we had one transgender individual. I don't know where he went and got surgery. It was a disaster, and the psychiatrist even said the surgeon should have lost his license. He looked like something you would have found on like those surgeons' worst nightmares or something off TV, off Bravo. It was a disgrace. It was horrible, horrible what that man had done to himself. I mean, he looked like that lion woman or something that you see like on the cover of magazines sometimes. It was, I can't even describe, you guys wouldn't believe it. I mean, there's no words to describe how ridiculous. It looked like basketballs were like on top of, like, you had your butt and then put basketballs on top of that, so it was like 3 butts. But separate, that they were like walking and moving. It was just ridiculous the way that this individual looked. I can't believe a surgeon let this poor person do it themselves. But you're supposed to do psych scraping before all that stuff. Look over the lips. It looks like one of those balloons that you like shape into a poodle. That's what they had for lips. Like the whole balloon, like the lips wrapped around the face. It was horrible. So. If there's a family history of suicidal ideation, that increases risk. This comes into play at the end of the lecture because we talked about how the family needs to be supportive once the patient is discharged. So there's a conflicting role right there. You're trying to provide patient education and get the family involved, but they could have a family history of suicide. And so you're trying to encourage the patient to process feelings and talk to the family, but then the family could also be a problem. So there's a huge disconnect there. If grief is playing a role, that's difficult, and obviously lack of employment. But how can we come into play and help in this aspect of lack of employment or increased financial burden?
Affirm the services you mean, them get some technical training or a job or
Mhm.
something.
We can get consults for vocational rehab and get social services involved. So this is very big, and you'll just have to know generally, and be able to apply it to an application type question that cyberbullying and bullying takes a huge psychological effect on individuals. And it's a huge risk factor for suicide and affects your younger populations, your adolescent populations. And this is one of the reasons why individuals are gaining awareness about suicide and mental health, because this is happening so often in our school systems. And this is becoming more and more of an issue because of, number one, social media, but we have horrible examples being set right now. I mean, regardless of like your political beliefs and stuff, I'd honestly, okay, regardless of who you voted for, I mean, President Trump, he's the president, that's fine, it happened, okay, we can't get over it, no one's gonna like get him and drag him out. But stop using like Twitter and stuff and setting horrible examples, you know, because other people see that and follow it. When you say ridiculous things and tweet it out and stuff, you know, then other kids and, you know, young people think it's okay to do those types of things. Setting a really bad example, just that's why you have a press secretary, let them talk. Such psychological theories. This anger turned inward, it was a theory developed by Sigmund Freud. And so we talked about anger in the last class. So anger, we know if it's uncontrolled and you don't deal with it, it can be, it can turn into what? It can turn into aggression. It can be expressed as aggression, but then everything becomes violent. If you remember on like the first or second slide, it talked about violence. And so Freud's theory was, if anger is not dealt with appropriately, these individuals who are obviously mentally disturbed, they express aggression, but instead of expressing it outwardly, they keep it inside and they express their aggression inwardly towards themselves, and i.e. they punish themselves by committing suicide. So regardless of who they're angry at, they take it out on themselves. This hopelessness and other symptoms of depression, this is where obviously depression, major depressive disorder, and the symptoms of depression manifest themselves in a way that the individual can't cope or utilizes, emotionally just has no coping skills or utilizes poor coping strategies and therefore commits suicide. Desperation. We'll talk about it later, but this would be kind of tied to an anomic suicide, someone that just doesn't have any connection with anybody, something that happens suddenly. If somebody had no connection for a long time, it would be more of an egoistic type suicide. But they're so desperate and they feel so guilty about something, they take their own life. Obviously, past history of aggression and violence, that trauma, boils up and they decide to take their own life. If they had shame and humiliation, like the example of my coworker that found out he was HIV positive, he had intense shame about that and just decided to take his own life. Durkheim's 3 social categories of suicide, you'll need to know this for the exam, so this is something to take note of. So egoistic suicide, this is more when an individual has been chronically struggling with mental issues for a good portion of their life. And the individual feels separate or dissociated from mainstream society. Because they're not part of any cohesive group, this increases their hopeless feelings, depression, and so on and so forth, and they take their own life. So they're very disconnected, they don't have any ties to any cohesive group. The exact opposite of egoistic suicide is altruistic suicide, and we're very familiar with this because we see it on the news all the time. This is the type that we're most exposed to through news and social media. It's someone who's very radicalized. And they're often motivated by culture or political beliefs or religious beliefs, so much so that they're willing to sacrifice themselves. So the altruistic suicide, very radical individual, hyper-religious, political, they'll sacrifice themselves for that belief. And your anomic suicide, it's a response, a reaction to changes that occur in the individual's life. So a response, a reaction to changes that occur in the individual's life. This causes them to feel separate from a cohesive group. And they can't cope with that separateness that suddenly occurred. So just something important to note, anomic, this is something that happens suddenly. There's a sudden break from a cohesive group. So there's a sudden precipitating factor that happens, just out of the blue that they can't cope with. Or that they feel will break them, that will separate them from a cohesive group. A cohesive group, that sounds very formal. A cohesive group can be like family, religious affiliation. If school's very important, they feel like they could get them kicked out of school, lose their job, something like that they feel intense shame for. For example, a great example of an anomic suicide, was anybody familiar like 2, 3, 4 weeks ago about the secondary school teacher that took his own life? Did anybody see that in the news? There was like a middle school teacher, he was male, and he was having an affair with like a 12-year-old boy in his class. And he got caught. And so he did FaceTime videos on like a bunch of different iPads for his family, dropped them off at all the family's houses, and people saw him. He skipped the school board meeting that morning where he was obviously going to get reprimanded and probably brought up on criminal charges. And then he went and he killed himself because he realized his life was over. He was going to probably go to prison. And this guy would not have done well in prison, let's just say that. Like, he was tiny, slight, like prison would have kicked his ass. So, and as well as other things, like it would have just been a mess. And so he realized that he was going to lose his job and everything he cared for, and so he killed himself. Well, there was a sudden factor that precipitated him taking his own life. Altruistic suicide we see all the time. Radical extremists blowing things up, in the name of whatever. So I'll make it very clear on the test. The example should be very obvious to you. I'm not going to try and trick you. Any questions about any of that? You guys comfortable? Okay. All right, so when you look at sociological theories, so factors that elevate suicidal ideation, we talked about pain and chronic illness. Connectedness, either the presence of it or lack of it, that's obviously going to increase or decrease the suicidal ideation. And that's what this point number 3 is talking about. When there's strong levels, no, that's not correct. When, in order to create or to complete the suicidal act, what do we have to be aware of as far as the environmental circumstances? So they can only attempt suicide if what? They have the capacity to make an attempt. So what do we want to do to the environment? Make sure it is safe. So we look at predisposing factors. Oh my God, I've got to get rid of this cough. I'm not going to ask you anything about genetics, biological factors. I'm not going to be throwing a question on the test to tell me about some cytokines and how they affect suicide. I'm not going there. We're psych nurses. We don't need to deal with all that. I am going to just ask you about deficiencies in serotonin and increased levels of testosterone. So those are the biochemicals you need to be aware of. Because what do we know that our psych medications do if we reflect back on psychopharmacology?
Increase serotonin, they're opposite.
Yeah, they're inversely related with what makes you feel good. So our medications, they allow more free-floating serotonin, norepinephrine, dopamine. So we want to be aware of those because that's something that will have already been tested on. And then testosterone, we know like roid rage and all that kind of stuff. Well, it's shown, that the aggressive factor comes into play. But deficiencies in serotonin can increase levels of suicidal ideation. Thinking I'm seeing like a hand over here, but it's like the bulletin board that's right by you. Keep thinking you're putting your hand up. I've been here all day. That's fine. Okay, give me a break. So like we've talked about, the important thing that all of these events, it's very sad that all these events keep taking place, but there has been increased awareness that's come out of it. So now professional organizations and the government, they are starting to pay more attention to the act of suicide and how it impacts the community and mental health as a whole. So when you look at assessment, what's the most important thing that you want to do whenever you're assessing an individual that you suspect has suicidal ideation, or maybe a plan for suicide? Just what do you guys think in general would be important to know?
How they try it before, and what do they do?
Yeah, if they have any active plan, how they've tried it before, what their history looks like. Because we know that we can gather information about risk factors. And so when we're looking at the nursing process, when we're gathering this data, as it relates to the psychiatric mental health nurse, assessments performed in which 2 stages of the therapeutic relationship process? Yeah. The pre-interaction phase and the introductory phase, those 2. And what differentiates the 2?
Client's not present.
Yeah, the client's not present in that pre-interaction phase. So this kind of outlines your physical assessment. You're going and you're asking them questions, age, their gender. You're doing things to, go do your head to toe and everything. But what also do you notice about these questions as it relates to the characteristics and risk factors that we just went over? What does it tell you?
Totally stressful.
Yeah, it tells you everything that you need to know about the risk factors that we've outlined in the first part of the lecture. So as you're gathering all this information and you're just going through asking them basic questions, you find out a lot about, well, how high of a risk do you have of carrying out suicide or being at risk for suicide. So we can gather a lot of their presenting symptoms and their medical psychiatric diagnosis by going through their history of present illness and then their past, if they have any information about past admissions or past hospitalizations. So this would be done in that pre-interaction stage. And then we can ask them, to explain in detail about suicidal ideas or acts and if they have a current plan. So we want to ask if they have an interpersonal support system. And like I said earlier, that's having that meaningful network of satisfactory relationships. So they're not going to have one in the hospital, or maybe they don't have one outside the hospital. So what are we going to do inside the hospital in the inpatient setting to address this issue? We're going to act as what? Yeah, a temporary resource to act as that satisfactory interpersonal support system. And we do that by doing what we talked about in past lectures about that therapeutic communication and that therapeutic relationship development. And we hope that we, build a good, identify a good nursing diagnosis, develop good interventions, and then we can successfully terminate the relationship in a positive manner and then transition them into outpatient treatment. So when you're looking at the suicidal crisis, when you look at the precipitating stressor, what would be an ideal situation for the precipitating stressor? Pardon me?
Could be temporary.
Yeah, that
Or they
it's
try to deal
temporary,
with it.
or it just happened, and it's like we can be like, okay, well, we eliminated the stressor, it just happened like 2 weeks ago, we got rid of it, and we'll treat you for a little bit, take these pills, and you'll feel better, and now it's all done. But what's probably the actual case that's gonna happen? What are we probably gonna be dealing with? Yeah, traumatic, chronic. My uncle's been with me since the age of 3. I'm 24, he still lives 2 doors down. We can't kill him, so I mean, we gotta come up with something else. So there's probably some type of chronic precipitating factor we're gonna have to deal with. We have to take into consideration the history, and then what kind of lifestyle issues are we looking at? Are there any other comorbidities? Are there any other adjunct psychiatric issues that we have to look at? Do you have any substance abuse problems? And so there could be all sorts of things that we have to take into consideration. All right, so we're, of course, like we've already said, we're asking about our psychiatric and family histories. We're also assessing coping strategies. And one thing that we do in the hospital is if they have poor coping strategies, we reshape to develop new ones. And so we use a combined approach to talk about how to develop the coping strategies. We push the individual to go to groups, and then we also give them what, in addition to that? Medications, because we want to do groups and medications in combination to build that therapeutic response. You can cross this out. I debated on talking about this, but that's not a short acronym. It's PATH1, that's a freaking sentence. So that's a horrible acronym, so we're not going to do that. I was like, there's no way you can remember all those words and descriptions. So this case, this chronological assessment of suicide events, this is something to be familiar with. I'm not going to ask you to describe it in detail on the exam or anything. But you want to normalize communication with the client. You want to ask about behavioral events and gather facts rather than opinions, and you know that from doing your nursing process. You want to encourage the client to give you data, factual data. You don't want to allow the client to deny suicidal ideation or generally deny or put denial and blame on other individuals. And then you want to create a chronological timetable of events. When have you had past feelings of suicide? What's going on, in the immediate past, recent past, and then what's happening right now. So you can paint a good picture of how the patient's feeling. Whenever you're looking at the patient telling us things is one aspect of doing a good assessment, but we're also picking up on other cues from the patient. So cues can be both verbal and nonverbal, and we learned about that in our therapy of communication. And so we also want to be identifying the whole, identifying and assessing the whole person, not just what they're saying. So with our nursing diagnosis and developing a good nursing diagnosis, we want to we want to know if the client has actually experienced any harm or has any active thoughts of harming themselves. You want to be able to set realistic goals for the client. And then we want to generally express optimism for the future. So what's the difference, and you will need to be able to identify this on the exams, this is something to make note of. What's the difference between no suicide contracts and a safety plan? What do you guys think? Yeah.
The safety contract, or the
Safety plan.
the safety plan is a backup plan in case something goes wrong, whereas the contract is like a plan for the.
Yeah,
where
like
you
just a
want it to
verbal,
go.
just a verbal yes or no. The safety plan is actually, because we always talk about including and involving the patient in their treatment. So the safety plan is very specific, and it outlines, if you feel suicidal ideation, you're gonna do what? You know, what activity will you do? Who will you call? Who will be your support system? What are the emergency resources that you can employ, and what are the numbers of those resources? Are you going to attend outpatient treatment? Yeah, this is about the safety plan. So it's very specific and it's individualized to that patient. And it also puts the onus back on the patient because they have to write it out. They have to specify what resources they're going to use, what actions they're going to take, and then they have to sign it, and then we simply witness that document. And it has to be completed at the time of them leaving the hospital. A no suicide contract is just a verbal yes or no. Can you contract with me that you're gonna be safe, and that if you feel like harming yourself, you're gonna come up and tell me? Yep. And they always say yes. And then, they might sign it and you might sign it, and that's it. Statistically, those have been shown to be very inadequate and, not very effective. But this safety plan, they've obviously had to take time to think about things, write it out, and so it decreases, from an ethical perspective, liability. And then it shows, as that patient was being discharged, they obviously were of sound mind and could think and had thought about, yes, I'm, in the right mindset, and I don't want to harm myself because I'm actually writing things out. Because you do have patients, and the hospital can get reimbursement, because there have been patients, it's happened at OLAP, I'm sure it's happened at every psych facility, where patients go out and then within 24 hours, yes, they do kill themselves. Well, according to reimbursement statutes and legislation, you're not eligible, and like Medicare and Medicaid, you're not eligible for reimbursement if you leave the hospital, the patient leaves, and then automatically kills themselves after they've just been in inpatient treatment for suicidal ideation. You obviously failed in treating them for that if they immediately leave and commit suicide. But if they have a detailed safety plan, it gets you off the hook for that. Now, nurses aren't good about making sure that they fill out their safety plan. So you'll get hounded about do their safety plan. So that's why you got this no suicide contract, and then right after that, clients need to be actively engaged. The nurse is caring for an actively suicidal client on the psychiatric unit. What is the nurse's priority intervention? So what do we want to do if we have an actively suicidal patient? What do we know right off the bat before reading any of this? We want to keep them safe. So you're like, keep them safe. Okay. So what's the option to keep